Where's the Mona Lisa?
I love it. So yes, please, everyone, put your name and your practice or where you're from or what you represent in AHP, your job in the chat. And that's how we're doing introductions. I really much prefer the personal intro, but we also decided that for tonight, we would actually take this 1.5 hour meeting and condense it to 1 hour because we thought no one would ever say, what? Not a 1.5 hour meeting? Come on. And so I really have the pleasure of really turning this over to the AHP team who are going to walk us through the topics for this evening. So I think you want to give another minute or two, Renee? How's the action in terms of people coming in? Are we pretty close to full participation?
No, we are waiting for some folks still. That's okay.
Okay.
And I don't know if you saw my message to you in the chat. We were going to ask Daryl to kick us off. Okay.
Yes, exactly.
I apologize if anyone can hear that. My dog is snoring.
I thought that was you. No, I'm joking. I didn't. It wasn't making a sound.
Are we ready?
It's like, wow, this must be a boring meeting.
Are we?
All right.
He had a really good time at the dog park today, so he's exhausted.
That's excellent. Way to go, Chewy. So we could give an award for the person who's zooming in from the furthest distance while we're waiting for a moment for more people to come in. I think Dr. Jeff Gardner has that covered. Zooming in from Arnett in Chemung County. Woo.
I'm here.
All right. Thank you for joining us. That is awesome. All right. So Daryl, I think I am going to turn it over to you and ask you to start us off your announcement.
Okay. Well, I just put in the chat that I'm the Director of Care Management, the Senior Director of Care Management, but not for long because I'm going to be moving on to a new role with AHP as a Senior Advisor for AHP on the clinical side of things. And I am delighted to tell you that Elisa Stetzer will be the new Senior Director of Care Management effective March 16th. Elisa is the current Director of Care Management for the Primary Care Network and has great experience in population health. She did a lot of work in Washington before she came into a position in nursing. She worked for the advisory board, which is a think tank in population health. She had her own consulting firm where she did consulting across the country, administrative consulting in the space of population health. She's done a lot of work in the area of care management and in teaming. She's a big fan of teaming, and she is a delightful colleague who I am really have been pleased to know and work with over the last few years. And I couldn't be more pleased that she will be taking the helm in care management. So I just wanted to let you all know that. And I will still be working on things like trauma-informed care and behavioral health integration and advancing health equity, but I will be working part-time and looking forward to the next chapter in my own professional life and enormously grateful for the opportunity to have served in this role over this time and really, really excited about what's ahead for care management. So just wanted to share that with everybody.
Daryl, thank you for that. I think it goes without saying that it's hard to imagine anyone else in that position. Because Daryl has really led all of this so beautifully in her amazing collaborative leadership style. And we're definitely going to tap into her consultant expertise for the maternal child health stuff. So don't you worry, pediatricians and family physicians on this call, you are definitely going to get more of Daryl Sharp because we're going to get her engaged in a lot of the things that we're doing, the fun initiatives and stuff we're doing in peds. But I think it would be really nice. It's hard in these kind of meetings to really do a major shout out, but I think like however you want to do it, you can unmute, you can go woo, you can clap, you can put the hands in your thing. Daryl,
thank you so much.
Best.
Thank you. Thank you.
All right. Okay, and so with that, then I'm turning over for the first part of our agenda, which is our incentive program overview. and an introduction to the provider engagement report. Turning that over to Renee and to Kim.
All right, let me bring up my presentation here. So Kim and I are here, and some other folks as well, to talk with you about our new PCP reward plan, to walk you through incentives, specifically the quality incentives. We've really made a major overhaul to the program, and we want to make sure that you understand intimately how this will work and how we will support you in optimizing your quality performance in order to optimize your incentives. So, please pop questions into the chat or feel free to pipe up at any point, but we will get started. And this is what we for this section, we want to talk to you about. So I just want to do a quick overview of how we earn gain sharing. And I'm sorry if I'm distracted, but I'm kind of solo tonight, letting people into the meeting while I present. So sorry. So I wanted to talk about how we earn gain sharing, just to give you a quick reminder, primer on that. Talk about the prior incentive plan, because we think it's easier for you to understand the new plan when you can contrast it with the old. And then I'm going to turn it over to Kim Povak, who was elemental in developing this new plan and putting together the data necessary to support our proposal here. We're going to talk about the new reward plan. She's going to talk to you about the specifics of the reward plan, and then do just a brief introduction to what is going to replace the triple aim report. We're calling it the provider engagement report. And she's going to help you put in context of how the reward plan and your progress towards incentives is going to be reflected in this new provider engagement plan. And then we're going to move on to the next topic on the agenda that you all received via email, where Christy's going to talk a little deeper about the provider engagement report, and then turn it over to Bob Kiso, who's a colleague of ours from UR Medicine's ISD department, very skilled in user experience, and we're going to count on his good work to facilitate a conversation with all of you to really get your feedback, because we really want to be certain that this report will meet your needs and be useful to you and support you in your effort to optimize your performance and to optimize your incentive. So with that, I'll get started. And I like to talk about the gain sharing equation, because that's important to understand. I think everyone's familiar with this graphic that's on the screen right now, the value equation, right? Value in healthcare is quality over cost. Well, similarly, the gain sharing equation, the dollars are earned by virtue of both our performance to quality and cost. And AHP only earns gain sharing when we hit quality targets and we perform under the budget. It requires both of those things. And the reason I bring that up is because even though that's how we as a network earn gain sharing and are rewarded, our prior quality incentive plans, we only paid you an incentive based on one thing, one aspect of that equation, and that was the quality measures alone. That was all that that's what earns you the incentive, was your performance to the Arcadia measures. So we felt that it was, and this is just a quick overview of what those incentive plans, they've gone through a number of iterations. When we started our first PCP quality incentive plan, we paid out at the provider and the practice level, and there was just a max and a base, an over and an under. If you earn 50 or more points in the Arcadia dashboard, points that you're eligible for, you earn the max. If it was 49% or fewer, you earn the base. Version 2.0, we went to provider only, same principle, and over and an under, but we upped the threshold, right? We upped the bar that you had to cross in order to achieve the max. It went up to 65% of points. And then the most recent iteration of our incentive plan, we got even more sophisticated, and that we introduced a bronze level. So instead of there just being an over and an under, there was gold, silver, and bronze, and each of those had thresholds, which you can see on the screen. And then we introduced an improvement bonus. So for providers who achieved an improvement in their percentage of points, 20% over the prior year, received an improvement bonus. But again, as you can see on the screen, it was all about just your performance to those Arcadia measures. It didn't account for performance to cost. Another way that we incentivize you is also through our gain sharing, right? You get paid gain sharing in August, September timeframe, August or September after the performance year. And that methodology was based mostly on quality and attribution. You earned the dollars based on your performance in Arcadia, and you earned a per member amount based on the size of your panel. The first iteration was just a base amount that every provider, every PCP earned the same amount, a base amount, and then there was an attribution that again was at a per member amount based on the size of your panel. And then version 2.0, we did introduce the quality aspect. So that's the most recent version of the gain sharing methodology. PCPs earned a base amount. They earned a dollar amount based on the number of patients on their panel. And then they earned a quality component. The quality component that you all earned on gain sharing was exactly the same as what you earned in that quality incentive that I reviewed on the last slide. So if you earned gold in your quality incentive, you earned a gold quality component for gain sharing. But we need, our goal in revamping this is to better align your incentives with that gain sharing equation, that PCPs will be rewarded based on both quality and cost performance, because it does, we can knock Arcadia measures out of the park, but if we didn't save money, if we don't beat the budget, there's no gain sharing to be had. So we want to partner with you more and incentivize you more around performance, both on quality now and on cost performance. So if there's no questions at this juncture, I'm going to turn it over to Kim Povek to walk you through the specifics of our new reward plan.
Okay, wonderful. Can you all hear me?
Yes.
Okay, wonderful. I'm doing some construction on my house, so there's some saws going in the background, so I hope you can't hear that while I'm speaking. Let me know and I'll speak up a bit. Thank you, Renee. We're going to start off by just going over at a high level what this new incentive plan looks like in combination to this new provider engagement report. And there are going to be three big changes. And I think it's important just to remember these as we go through, and it's kind of how I think through it and how I remember what are the big changes. The first big change is that instead of 2 payments each year, we're combining those 2 payments into 1 payment that will be paid out in September. The second change is that you'll no longer receive that quarterly triple aim report. It will now be replaced with the provider engagement report, which we'll preview tonight with all of you to get your feedback on. But in essence, that provider engagement report is going to let you know, to inform you how you're performing on quality, just like we have in years past. But the third change is that we're now adding a cost performance component and a citizenship component. So those are the three big changes. The last item I want to highlight here is that third bullet point. One of the items we had to take into consideration is the attribution or the population that a primary care physician brings into the network. Part of attribution coming into the network means we get more dollars from the payers. We get that PMPM. So if we have a provider who brings 2,000 patients to the network, it's going to bring in more PMPM or more clinical integration dollars that supports care management and our infrastructure, rather than a physician who may only bring in 100 patients. So we've capped the quality reward portion of this incentive plan for providers who bring fewer than 500 patients to the network at the silver level. So again, we're just saying you're bringing in fewer patients to the network, and we want to appropriately reward the volume and effort of that work. Next slide. This just pictorially represents what Renee and I have started to uncover. In essence, what you see on the top of this slide is the old reward plan. You would get those quarterly clinical integration payments, and then in March, you would be paid based upon for the quality, that quality incentive payment. And in September, you would receive gain sharing. And that was what Renee had described, that base attribution and quality component. The lower half of the PowerPoint slide represents the new reward plan. And again, we're taking that March payment and we're bringing it over to September, and we're going to reward you once. And it'll be based out of a larger pot and also be incentivized on not only quality, but also cost. And on this slide, that's represented by IPCs. IPCs are integrated practice committees. We borrowed the term from Baylor Scott and White as a health system in Texas. And these IPCs, they are utilization and cost-driven initiatives. And so we'll get into more of that in a moment. We've also included RX pharmacy in that bucket. The third bucket there is citizenship, and we'll be diving into the details of those momentarily. Next slide. Okay, so what does this new reward plan look like? So what we've done is we've broken it down into 3 components. We'll reward you on the quality measure component. That'll be worth 60%. The IPC and pharmacy, that cost component will be worth 30%, and citizenship will be 10%. So how do you earn this? What does one do? So if we go back up to quality measures, this is based upon performance in Arcadia, just as it's been every other year in the past. One addition here, Elizabeth Sharp, our Director of Performance Optimization, through discussions, we're gonna break out this quality measure percentage even further. So really 50% will be based upon your performance in Arcadia, while 10% will be based on a specific quality measure initiative that Elizabeth and her team is working on. And in this case, it'll be depression screening. So your quality measure component will be 50% quality measure performance, 10% depression screening performance. 30% will be that IPC and pharmacy. Part of this new provider engagement report will be providing you information about your cost performance around specific initiatives that AHP will be supporting you in. And lastly, citizenship. And I remember the first day I got to AHP, Renee told me about her dream of really including a citizenship component in how we engage our practices. And so it's finally coming to fruition 4 years later. So I'm going to let Renee talk about that more towards the end. But before we move on, do you have any questions? Any questions about this pretty seismic shift? Okay, we will continue. Okay, so the provider engagement report. We refer to this internally as the PER, so naturally a cat showed up on this slide, so please humor us with a laugh. This will be the new Triple Aim report. I think one of the things we heard in feedback from that Triple Aim report was that people loved the visuals. They loved what it was telling them. It was information some folks had never seen before, but they wanted more information. They wanted this to be actionable. They wanted the patient list, and they wanted to be able to interact with their patients in a different way because of this report. So this is some of what we've included in the provider engagement report. It's really going to start out on the face sheet with a snapshot of your cost and your quality performance. And we've blended that together, just as Renee mentioned, that value equation, it's quality over cost. And so we're going to show you what your value equation looks like. And I'll dive into that just a little later on. We plan to distribute this quarterly, which was the same sequence that we were delivering it in previous years. And what we're going to do is we're going to highlight opportunities for you all to continually improve quality and cost performance. I think one of the biggest advantages of this report will be its ability to be customizable. So for example, if I'm a PCP and I'm really struggling with LARC, LARC will show up on mine, but if Elizabeth is just doing great on LARC, something else is going to show up on Elizabeth. You'll always have something in that quality, cost, and citizenship component, but it will be customized to your greatest opportunity. Next slide. Great. So this is a snapshot of what the provider engagement report will look like, or the face sheet. And I know Bob is on the phone with us, Bob Kiso, to talk and really ask you questions about the design, how you want to see it, where you want to click. So for this portion of the conversation, the goal of showing you what this looks like is really to demonstrate how our new reward or incentive plan is going to mirror our provider engagement report and how the two function together. We really believe that one cannot function without the other now. So Renee, I think if you give us one click, I think it'll highlight the cost quality section. It does. Wonderful. So at previous pediatric PCP advisory committees, I believe Chad has come and shown you the cost quality grid. That's what we refer to it internally. And what it is it's a chart. And on the x-axis, running along the bottom, is quality performance. So the left-hand side of this cost quality grid would represent low quality performance, while the right-hand side of this grid would represent high quality performance. On the y-axis would be cost performance, total cost of care for your patients. And the lower left-hand corner would represent low cost. The upper left-hand corner would represent high cost. So the ideal spot to be on this cost quality grid is in your lower right-hand corner. So if I get my cost quality grid and I'm up here, so I'm high cost, and my quality is pretty low, we want to slowly move you down here. If I'm up here, your provider engagement report is really going to focus on ways to lower your costs. If you're over here, your provider engagement report is going to focus on ways to improve your quality. So it's going to act as a compass for the rest of your report. Renee, one more click. Maybe 2 clicks. There we go. So what we want to do here is demonstrate just truly how what we're rewarding you for will be represented in your provider engagement report. And this is really so that you'll know how you're performing and where you might need to make some tweaks. So as you can see, this quality measure performance is 60%. And as we talked about earlier, 50% will be based on your performance in Arcadia. And 10% will be based on depression screening. So both of these will be represented here. And internally, we're trying to figure out ways so that you can see which portion of that 60% you're on track to capture. Just so that you can have a gauge on how you're doing performance-wise throughout the year and what that might translate to in terms of dollars. Another click, Renee? This IPC pharmacy component is next. It's 30%. As you can see here, for our family medicine physicians and our internal medicine physicians, we're doing a 5-contact readmission program. It's heavily based in care management and on seeing patients within a week after being discharged from the hospital. That'll show up on the adult portion. Pharmacy costs, we have pediatric and adult focused pharmacy initiatives. So the pediatric one will show for all of you. And then pediatric LARC will also be included in the IPC pharmacy portion. When we presented this at PCP Advisory last week, we had some questions about how specific and how particular are we going to be? Are these going to be process metrics? Are these going to be outcome-based metrics? And what we're really trying to do is tailor it. So for 5 contacts right now, we're really only able to measure process at the moment. And we think that's fair. This is the beginning. We want people to be successful. And we have pretty good indicators that our process measures are pretty good indicators of our outcome measures. So some of these will be a mix, and those will be highlighted on here for you too. And Renee, the last section, that citizenship component. As you can see, there is a box here for citizenship as well. And Renee's going to spend some time going through the citizenship component of it in the next several slides. But before we get there, I was curious if anyone had any questions or comments on the 60-30-10, the change to 1 payment a year in September, and the new concept behind the provider engagement report.
Kim, I will just say this is not a group that usually has difficulty offering feedback or engaging, but I think people are probably trying to take it in a little bit, and some questions are, so I'm going to just say to people, you don't feel like speaking up and you want to put something in the chat, go ahead. So Janet Cranshaw's just said she missed what IPC stands for. Can you go through that again, please, Kim?
Absolutely. So IPC stands for Integrated Practice Committee, and it was a term we borrowed from Baylor Scott & White, a large health system in Texas. And basically what they did is they used this IPC structure, this Integrated Practice Committee structure, to drive forward utilization and cost-based initiatives across their health system. So one of the characteristics of an IPC is it's something that AHP in and of itself can't do alone. We have to partner with the hospital system, possibly with the nursing homes, with home care, to really engage on driving utilization and cost-based initiatives.
So I'm gonna be the person speaking the chat. So I'm going backwards here, but Liz Walsh said, could you give an example of the citizenship piece? And Renee, are you going to talk a little bit more about that anyway going forward?
Yep.
So I'm going to have you pause on that for, I'll have you pause on that for 1 second and just say that, yes, just to Carolyn's comment, that we are fully aware that for certain practices, Arcadia is not picking up the depression metrics. So I was going to bring that up if no one else did. That will be fixed before this is, I mean, it's in the process of being fixed, but that will fully be fixed before this is rolled out. So I just want to reassure folks that, you know, the intent of this is to make sure that our system is picking up all the things that it needs to pick up. So the information that you are getting and are responding to is fully accurate. So thanks, Carolyn, for bringing that up. Renee, do you maybe let you, oh, wait, there's one more. So this is a piece of feedback from Toby Burchin. Do you see that, Renee? Go ahead.
I do. So Dr. Burchin is saying, I can imagine the stress a single payment at the end of the year will put on the cash flow for smaller practices. And I'm going to back up a little and draw your attention to this slide, because yes, we are, so under the old reward plan, we had a payment in March and your gain sharing payment in September. But all along, those quarterly clinical integration payments are still in place under the new reward plan. You're still getting those on a quarterly basis, and that's based on your attribution. So that schedule hasn't changed, and for some of our larger practices, that's pretty significant dollars. The quality incentive payment, you know, under the old plan at max recently was $6,000. So, you know, our hope, I appreciate your comment, Dr. Burchin, but we're hoping that combined with the fact that the clinical integration is still on a quarterly basis, that this hopefully won't put too much stress. And I welcome everyone. That's important for us to hear if you think that is the case.
Anyone else have comments on that in terms of timing and that change?
No. Okay, Kim, are you all set? Was there something you wanted to?
I was just reading another comment in the chat. The last thing I just wanted to wrap up with is we spent a lot of time looking at the impact that this would have on physicians who had large attribution versus physicians with smaller attribution, or physicians who tend to perform better on quality or lower on cost, and how is this going to impact them? Because truly, you were all on the front lines doing this work, and so we wanted to make sure that folks were rewarded properly for the work they were doing. So we think we landed in an okay spot. We recognize this is new, so we'll continually ask for your feedback as this gets rolled out. And so we'd really welcome that as we move into the future with this. Renee, I'll turn it over to you.
Okay. Thank you. So the citizenship requirement is, you know, exactly what you think when you hear citizenship, right? It's rewarding you for the activities that demonstrate your engagement, your interest, your stake, your sense of ownership in our organization. Every one of you that are on this call tonight are participating in a citizenship activity. And I'll draw some more examples of that, but I just think that's important for you to know. You're here tonight, you're engaged, you're good citizens, you're taking part in the important work that AHP is doing, and by lending us your good thinking and your experience. So just wanted to make that clear. So how does one satisfy the citizenship requirement that will equal 10% of the incentive for which you're eligible? Well, it's going to be awarded on an individual basis. The dollar amount will be awarded on a physician basis, but how you earn it can be based on both a practice level activity or an individual activity. And I'll explain what that means in a minute. There are practice components that if two practice components are satisfied, then every physician in the practice will earn the citizenship incentive. But let's say the practice isn't doing those activities at the practice level, then we'll look at the next slice down and we'll look at the individual physicians. And if a physician has satisfied 2 components on the physician's citizenship list, then that physician will earn the incentive. So I'll go next into talking about what the citizenship component, what those activities could be for the practices and the physicians, and then we'll walk through a quick example. So some examples of what it is that will earn it for the practice, which means if 2 or more of these bullets are satisfied in the year, then every physician in the practice will earn the citizenship incentive. Your practice manager attends 2 or more practice manager meetings annually. We have found that some of our highest performing practices have the most engaged practice managers. They're such important parts of your team, and they contribute so much to your success meeting AHP's accountabilities that, you know, we think this is a citizenship activity, that by virtue of your practice manager, that you support his or her attendance at our activities, we'll check one of those boxes for citizenship. That you pilot or participate in an optimization or administrative project. Example of an administrative project would be Vatica, which isn't something really that would apply in the pediatric space. Or an optimization project like the lead screening or the retinal camera that you put in your practice. So piloting or participating in something like that would earn, you would earn the citizenship incentive on the practice level. Pharmacy team engagement, you're taking meetings with our pharmacy team, you're participating in an IPC, which we'll talk more about. You have an active assigned practice champion. That's something we want to roll out this year, where you would assign, I won't get too deep into it, but essentially someone in your practice would take responsibility for the relationship between AHP and the practice. And we'll talk more about that in the coming months. And another practice level citizenship activity is engaging with AHP clinical leadership around the provider engagement report. The provider engagement report comes out, Chad gives your office a call, or LJ gives your office a call, wants to meet with you, you take that meeting, you have a practice meeting with Chad or LJ, that would be one of the components that would satisfy it at a practice level. At an individual level, a provider who attends clinical grand rounds or another type of AHP information session, allowing email communications would earn you. That's a really easy one that would check one of those 2 boxes that you need for citizenship. Many of you do receive, most of you are accepting communications from us, but some providers do unsubscribe from our communications. Serving as the champion, accepting new patients at the time of incentive calculation, not a problem for probably any pediatrician in the room right now. Serving on a physician advisory committee, like the Pediatric PCP committee, or serving on the AHP board or board committee. So, as you look at the physician list, I'm sure you can see that most of you in this Zoom session are certainly on an individual basis earning it. So how does this work? The practice earning it versus the docs earning it. I want to just walk through an example. Practice 1 has a practice manager who comes to every practice manager meeting. So there's one component checked off. They did the retinal camera project. They accepted a retinal camera from AHP and are really working on their diabetic eye measure. Component checked. They meet regularly with our pharmacy team to talk about lower cost alternative prescribing. So this, at the practice level, this practice has satisfied 3 of the citizenship components, and they only need to satisfy 2. So every physician in practice 1 earned the citizenship incentive based on what the practice did at the practice level. Now I want to talk about another example where that's not such a happy story. Practice 2 doesn't do any of these activities. Their practice manager doesn't come to anything. The practice hasn't participated in any of our initiatives, IPCs. They're not meeting with pharmacy. They don't have a practice champion. They're not checking the box. So because they haven't, we're going to stop looking at the practice level now. They didn't do it. Let's look at the individual physicians now who are in practice 2. Well, Dr. A in practice 2 does accept email communications from us, and Dr. A is also serving on, let's say, the Pediatric PCP Advisory Committee. Dr. A earned the citizenship incentive. They earn that 10% of the reward plan. Dr. B, however, only allows email communications and doesn't do any other activities with AHP. So Dr. B would not earn that 10% portion of the incentive. Okay, so that is the end of the citizenship conversation, or my presentation rather. So what are your questions about that? I'm really interested in your feedback, because we fooled with this one a lot to try and strike the right balance between what we expect from the practice on a macro level, and absent that, what we would expect from a physician on their individual level. So I'll stop there and open up for questions. This is very unlike you guys, okay? You are
they're like, I don't know, to like
right?
shake them all up. Like, I don't know what we're gonna have to do, like make you all unmute and just shout out once, like really loud, or sing a song together or something. I don't know. I'm teasing you all. One thing I would just ask, that we've got some nurse practitioners as part of this team, Renee, when you're talking about the citizenship, does that apply to nurse practitioners in the practice as well? Or is that only for physicians?
Right now, everything we're talking about with you is around the physician. We are still working on the next little piece of this, which will include those APPs that practices have enrolled. One thing I don't think we mentioned at the beginning of our presentation that's important for everyone to know, well, when does all this begin? Well, as far as the new reward plan, you will be subject to the new reward plan for the 2022 performance year. Okay, so it's not this performance year. None of this applies right now. How we've been paying you, the quality incentive will and gain sharing methodology will likely remain as it has, although I do remind everyone that's always subject to our board on an annual basis. But this reward plan that we're talking about will take effect in 2022, and we certainly expect by then we're going to be have a way to integrate APPs into this plan. But great question, LJ. Thank you.
Yeah, and I think there's a question here about speaking to pharmacy engagement more in the pediatric space, because I think it's a little different. I think we all recognize that some of the greatest pharmacy costs really lie in the adult care space, not in peds. But if some of you will think back to, we did do a pharmacy initiative where we looked at prescribing of high cost stimulants, remembering that Vyvanse actually turns out to be like really a high spend compared to other ADHD medications. So we're going to bring our pharmacy team back with you all to be able to talk about, what in the peds space will make sense for that. But again, looking at that for 2022. But I think the whole goal with this, right, is to bring this to you all now, to get feedback, have time to, to get this right so that it makes sense, so that people are engaged before it gets rolled out. So this doesn't get like, oh my gosh, somebody just changed the rules of this game, like what happens throughout this whole last year of COVID, where people keep changing the rules and the regulations and you have to scramble to keep up with it. This is to get ahead and to allow you an opportunity to speak to it. I think there's a few comments in the chat for people to see. Renee, I don't know if you're looking, and Kim, but Toby,
I am.
it's clear. And Doug has
Great.
a comment in there too.
Exactly. Toby, thanks for that comment. That's exactly right. That's the point of this, is to reward practices for their engagement. And Dr. Bennett, thank you for saying that. That's exactly what we're thinking in terms of the number of possible opportunities. And there's plenty of opportunities that any practice ought to be able to meet, or any individual provider could.
Okay. There's some questions about how this will be presented to the practices. And I think there's plans for that once things are solidified with this, correct? To be able to roll this out. So it's not just to this group, but to actually the practices as a whole.
We are absolutely planning to have a virtual clinical grand rounds that you'll be learning more about. And this will be a major part of that, is to share this with the practices. And as far as how you have a pharmacy question for one of the pharmacists, can I just shoot someone an email? Yes, Toby, I will message you. The pharmacy has their own email address. I don't know if anyone from pharmacy is on the call tonight.
I just looked, I don't think so. So yeah, Renee, do you mind maybe just putting that right into the chat if you don't mind, for everybody, so that they have that? Amazing.
I will do that. So if we're done with the citizenship conversation, I want to make sure we have enough time, because I know we're running short here. So I want to turn it over to Christy to introduce the next portion of the agenda.
Thank you. So let me My pleasure to introduce Bob Kiso tonight. So he's our Data and Analytics User Experience Director at URMC, and we've had the pleasure of working with him to help us shift from this old triple aim report, which was paper-based, to a new online interactive dashboard with drill downs and all. So tonight we're going to show you an early prototype, and we really want your honest feedback on this. It's important to us to get and incorporate your feedback into this process. It's very iterative and collaborative. And we want to make sure this is easy to use, has meaningful information, and it's timely. And it's more than you can get out of Arcadia. So where we're going to show you things with measure quality, not specifics tonight, but when you get it, it's going to be Arcadia plus, way better than what you get out of Arcadia. So I want to give Bob the bulk of the time here, so I'm going to, stop talking and let him show his screen, and let's take it away.
Oops. Let me open up and close this. All right. Well, thanks for having me. I am, let's see, opening up this screen. Okay. So you're looking at a dashboard, I hope, right, everybody? Is that true?
Yes.
Okay, great. So I just want to walk you through, and I know sometimes some of you have had experience with this in the past, looking at these prototype concepts. I really just have tonight 3 screens to share with you of a dashboard and then a drill through, a drill down, as Christy mentioned. So usually what's best is for me to just do a little bit of a walk around the dashboard, and then I have a few questions to ask you at the end of that. So first, you'll see at the top we have what we call a masthead, and the name of the report, provider engagement report. There's a last updated line, so you'll know when the information last changed, last updated. Up in the upper right-hand corner, this is picked at random. It would be the name of a practice and a provider, if it's an individual's name. This is a placeholder and a picture of a stock photo, and then the logo in the upper right-hand corner. So this gives you a little bit look into the branding and the person and the profile of who is looking at this report. Another thing that's important in the masthead is what we call a toggle, and you'll see practice and individual. So that's a toggle, a switch. It would, right now it's set to practice, and then it will, I'll show you in a minute that we toggle over to the individual. So the particular PCP could look at her practice and her own metrics. Then walking around the dashboard, and we've covered this, so I don't have to go into great detail, but cost quality is in a banner kind of approach first, and it's sharing some of the information. And we're still looking at the different ways of communicating this information compared to even what Kim showed in the previous, in her screen grab. This talks about a per member per month number for cost, and then a look at points captured. And then, so that would then be a drill through. Those double arrows at the end would allow you to go to another page. So at the dashboard level, you're getting a quick look at these 7 areas that are called tiles or cards. Quality measure we talked about, and that has a look at, looking at the number of points, 46% out of the possible 65. And then we look in the middle, depression screen, and follow-up is showing again on that this particular color shifts now to green. It's showing this practice is on target, 4,032 out of their total population, 75%. Then moving to citizenship, you'll see that this is showing 50%, so 1 for 2. The other thing I want to mention at this point in citizenship, you'll see a couple of these quick wins. What those are a quick look at an answer as to what I could do, what a user could do, what the practice could do rather quickly. These are an example here showing that you could attend clinical grand rounds. These are, the full list is on the drill through, but this gives the user a quick look at some answers as they're navigating this dashboard. On the bottom row, you'll see readmission. I'm going to share that in a little bit. I know it may not be may not pertain to everyone on this particular call, but I'm going to share what a drill through in a minute looks like. It happens to be on readmission, and then moving along, and that's on for context 3, 4, and 5. That particular detail we'll see in a minute. The pharmacy cost there is showing a benchmark, and then that it's on target for at 31%. And then under LARC, we're showing, in this case, we've talked about 3 main checkpoints. And so if there's overview training, if there's been placement training, and if there's actually been any placements performed at this point, this particular practice is at 66%. If we toggle, so this is what the practice dashboard looks like. If we toggle to this particular individual, actually doesn't have a pediatric LARC responsibility. So we're showing how in some cases, some of these, like readmission, may be removed from some physicians, from some, PCPs in this case. We're showing that I'll toggle back, and you'll see that this particular individual is doing quite well because of the scoring of the number of green that you see here. If we toggle back, we're showing about 50% here is green, and then in this case, this individual again is doing well, and you'll see that we're even considering conversational language at the bottom of this in a footer. You'll see at the bottom it says looking good, you're on target for 4 or 5 performance initiatives, 3 months remain in the year. So this gives the PCP a chance to understand her performance before she drills through into this drill down. Now I'll jump ahead and show you what a readmission looks like. And this particular drill down has, again, the masthead, everything stays in place, except now we're on a particular page. And you'll see from left to right that in this case, we're talking about specific metrics or measures being shared on what we call context 3, 4, and 5, of course. And then it's showing the percentage of completion of that. And we're showing also, as you move to the right, that we have 5 most popular common discharge diagnoses that this practice is seeing. That's a quick hit. And the as is a quick, what we call a donut graphic, which is showing 12.5% of a readmission rate. Below that is detail, and that is a patient list. And we're showing EMRN, that would be an actual patient name. This is placeholder text for obvious reasons. We're just giving you an idea of what the detail could look like on the final piece. And so that's a pretty quick run through of the dashboard. I've been talking a lot. Does anyone need to chime in on anything, or should I keep going? Or any overarching comments, anything anyone wants to share, like immediately, let me know. I'm all ears. It's been a quiet group so far.
Yeah, feel free to unmute, you guys. Yeah, feel free to take yourselves off mute. I know people have been putting things in the chat, but it's nice to hear your voices. So I think that, the hope is that this will be much more functional and actually more supportive and helpful of your work, and be able to, like everyone has been talking about, tailor to what you would be doing as a pediatrician or as a family physician, depending on the age range of patients that you're working with.
Right.
So thoughts from folks who used to use the old triple aim, quadruple aim report?
This is Doug. Yes.
Thanks,
I
Doug.
feel like this is much more clear than the current online reports, which are convoluted and sometimes not up to date, and sometimes are hard to load up. So this should be much clearer. So, so far it looks good. It'd be nice. Is there any dummy thing to set up to play with it to find out how it works? It's going to only go live, and then we get to see how it works.
Yeah, we would expect there should be some base training so that you can understand how it works. Right now, we're looking at screens, but after at a prototype stage, yeah, there will be opportunities to look at this dashboard and get comfortable with it through limited training. I'm not sure exactly how we're going to unfold that yet, unveil it, but it's something that we would be able to share with you so you become comfortable with the dashboard.
Good.
Thanks. And on on that point, and maybe this is a first question for everyone. I know this is a prototype in the dashboard. As we were just discussing, does anyone else see? Could you envision yourself interacting with this in a comfortable way? I know we just heard one quick answer to that. Anybody else? And does it feel? If you can give me that kind of feedback on if this. It's what we call ease of use. Do you see that tendency when you see these designs that anyone else could feel that way about this dashboard, or the opposite? Any other comments on the ease of usability, comfort level?
This is Ed Lewis. I second Doug's comments. I think this looks a lot more usable. My only concern is the accuracy of the data, and I think somebody had mentioned, some things aren't getting captured all that well. How, if there's an issue with data, how easily is it corrected?
Yeah, right now, so again, if we look at the case by case, depending on which drill through we're in, as I understand it, the data could be very relevant to what we're saying in the upper left-hand corner to last captured date, last shared date. So I understand what you're asking, and the best designers of dashboards can do is give you that date so that at this date the level of confidence is very high that this is correct.
Dan, the other thing I'll jump in and say too is that especially in the beginning, we recognize there's going to be a lot of tweaks along the way, and we want to make sure that you're being rewarded on what you're doing. So if we need to go in and manually clean up some denominators, and I'm not talking about in the data, but if we need to sit down and have a discussion and say, we recognize this denominator is wrong, and we're going to actually give you the reward because you really hit it. That's what we want to get at. We want to reward good quality. And if we have an issue, if we know we're going to have an issue with X, we're going to provide wiggle room, or we'll lower that threshold until it's corrected.
I'd like to chime in as well. There's another question here about, is it claims-based data, or where is this coming from? And just general concerns of data quality. These different components are going to be pulling data from a lot of different sources. So it's not just Arcadia data, and it's not just claims data. So we're working really hard with our analytics team to make sure that we're getting good quality, clean data, and that it's represented accurately here. So, we're not going to be presenting things that we know are wrong and holding you accountable to things that we know are wrong. We know there's some ongoing issues with the depression screening data, and we're working hard on fixing that. And we won't put it to use until we know that it's good.
I would add one thing about the depression screening piece. I know that the optimization team group is working actively on this, both in terms of capturing the screening, but then also the questions that are coming up multiple times here about what is actually being looked at in terms of accounting for follow-up and how will that work. There's some new things that have come out with the depression measures so that the team is looking at that. And I can assure this group, even if we don't have a PCP advisory group that we can bring it back to, I would love to even convene a smaller, like a 30-minute meeting over lunch, something to have the optimization team be able to review with those of you who are interested, what that will look like as it's built out. So you have the opportunity to give feedback. Does it make sense? Will that work for your practice? Some of you have seen some of the pilot design for that, but I'm just reassuring Liz Walsh, and I'm seeing Carol Gagnon, and obviously other folks in this space. For all of you, we want to make sure that this is really, the goal is not just to check a box, right? Even though we're box checking in some ways with this, the goal is to make sure that your patients are not just getting screened for these things, but then we're helping you to capture it in your record in a meaningful way. It's being counted and they're actually getting to the service that they need to. So I think that's at the root of everything we do, is improving the quality and the connection to care for our patients. But depression has been a little bit of a long road for all of us and much more tricky than we had realized in working with the EMR. So hang in there with us. Everything we learn out of the depression screening initiative totally informs anything else that we do, particularly because screening and response to screening is so important.
LJ, when do you expect to roll this out?
So I'll defer to the team for a minute where they talk about when they plan to roll out the provider engagement report, but the active work on the actual measures and these initiatives is ongoing right now. So we are hoping to get this all cleaned up and get the depression screening stuff set over the next few months, I would say. But Christy, do you want to comment on the actual rollout? Oh, you're muted.
Muted as usual. We don't have an actual timeline right yet. We are working on a prototype, and through that prototyping, we're figuring out how to best model the data and put the components together. And we still have some design work to do around some of these drill downs. We just showed you readmission as an example, but there's plenty more work to do here. We also need to partner with our ISD team at URMC to make sure that we're really building this as a robust and, most importantly, a secure system, because we're going to be showing you patient lists, and we have to make sure that that is secure and that only you are seeing your own patients. So it's going to take us a little bit of time to figure out the exact time frame, but we do want to get it out to you this year so that you can start to work with it before you're being held accountable for the performance that this is reporting. You may see early versions of it with AHP users using the working prototype and showing you at various meetings, but this isn't going to be the one and only time that you're seeing this. This is an early design. We plan to come back with a prototype and show our progress and get more feedback as we go along.
LJ, if I could just jump in and address the issue of depression screening and follow-up, just to tell everyone that the follow-up is going to be in line with the CMS preventive care and screening follow-up plan, and that has age-appropriate buckets where follow-up fall under, and it's like 5 buckets that meet those requirements. And what Elizabeth and her team are working on is exactly what was mentioned in the chat box. Is it's going to be a checkbox that would be entered to say, I met this requirement, that requirement. Just to give you an idea of what those buckets are, there is one that says additional evaluation or assessment for depression. So under that, if you identify someone with a positive PHQ-9 and you give them a follow-up appointment to address that, that meets the requirement. Suicide risk assessment. If an assessment is done at your practice for suicide, further assessment because the PHQ-9 number 9 criteria was positive, that meets the follow-up requirement. Pharmacological intervention. If you decide to start an antidepressant, that meets the requirement. And then the last bucket is other interventions or follow-up for the diagnosis or treatment of depression. So very generic, and allows you to check the box and say, I did address this positive screen. So it's going to be relatively simple, relatively easy, and then you with your patients will decide what falls under that category. We just want to capture that you address this measure in some way.
So I think we're getting a lot of very positive volunteering to help. So I think Elizabeth and I can take that and look at that and figure out a way to get some very specific feedback around the depression screening, particularly the follow-up piece. I know the validation thing is ongoing. So we say this is meetings being recorded. We have the chat, so I'm actually not taking notes of all your names, but we will capture that and come back to you. And Elizabeth just said her audio was cutting in and out, but she and I will follow up on this, which is what I had said too. So I know we are at 8 o'clock in our 8:30, in our meeting that goes till 8:30, but I said would end at 8. I would like to offer the opportunity to continue the discussion a little bit longer. If somebody does need to step off, we understand that. But I think I want to continue any questions or opportunities for feedback to Bob and to Christy to continue. So
Great.
Please keep up your comments.
Nice. And I could prompt it by a very simple question. Anyone who can stay on. When you see this, knowing it's a prototype, do you see yourself in a design like this, a dashboard, frequently or infrequently? And what would that number be? If anyone could tell me, like, just once in a great while, every 6 months, every 3 months, you know, how often do you see yourself in this often? Frequency question.
Feel free to unmute, you guys.
Oh yeah.
I'll unmute. This is Liz.
Yeah.
Hi. So the first question I have is this a replacement for Arcadia, or is this in addition to Arcadia?
In addition to Arcadia.
Okay. And so the trick becomes that any report that requires like stuff to have been looked at in, you know, the previous weeks is always going to be behind as compared, and often, like, for example, my kids that are behind on their immunizations, and you drill down and you figure out exactly which patients are on your list, right? And then you look at, they all came in this week, right? And so there's, from my perspective, I use these kinds of reports as a basic, like, eyeball it kind of a thing, where you say, okay, are we pretty close? Yes, we're pretty close. Or we're way off. There must be something, either we know we're doing it and we're not capturing it because we're not checking the right box, okay? Or there's something that we really need to do differently. And we use our own EMR's reporting systems for actually like making changes versus looking at a specific group, you know, listed on the website saying this is the group of people that we have to address, because it always ends up being chasing your tail, is my opinion with that, because you can't keep it up to the minute. And with so many of these things, it's like, you know, 3 or 4 days difference of when you get the report and what's happened during that time.
So Liz, I think I would mention too, I think in terms of a substitution, it's really more a substitution for that triple aim report, which was supposed to be able to give kind of the individual provider, you know, their sort of snapshot for people who weren't going in and looking in Arcadia necessarily, but could sort of catch a, you know, sort of like you said, like the quick like overview. How am I doing? Am I pretty much knocking out of the park, or, oh boy, it's Q2 and I'm not doing so well. Maybe I need to look at this. But the beauty of this is it allows you to look at your practice too. You know, that toggle switch is kind of nice in that piece. So I'll turn it back to Bob.
No, that's good. I appreciate those comments. I understand the refreshing of the data and how quickly you need to get information from maybe a different source. And I do understand that. I think that helps me a lot. I guess related to that, we use the word actionable. When you see a dashboard like this, do you feel like I know what to do? I know where I stand. I know what to do. And I know on the heels of that comment, I'm kind of curious still, like, if are there any other comments? Like, is that how you might be able to view this dashboard? Is that this data that I'm seeing, I now feel that I can take action with?
Absolutely.
Okay.
But again, it all depends on the accuracy. And if we start looking at this and, after the first quarter, it's, capturing 65% of my data, then that makes it very difficult, and it becomes very time consuming to try to get that caught up. I often feel like we are a checkbox society now. Unless you check the box, you didn't do it. And it's very easy sometimes to miss checking it, or you have a conversation and you cover everything that you need to cover, but if you didn't check the box, it didn't exist. And that, that bothers me. But if it all depends on the accuracy of the data, and especially if, for those of us in private practice who aren't using Epic, we need to make sure that Arcadia is capturing everything in our EMRs. I mean, obviously, probably the vast majority of us are probably using MedDent, and I think it's really important that interface works well, with very little need for us to input things.
Ed, if you don't mind, if I can just follow up quickly from that. Part of our hope for the provider engagement report is that it's directional, that it can point you to areas of focus. Absolutely. I was reading through some of the chat, and some of the information will be old by the time you get it. And that's a tricky part. What we're hoping is to make this as forward-looking as possible, so that the information you're seeing here, some of it we hope can be actionable for you, but some of it we hope will prompt a redirection in the future. And so the other component we're hoping to engage you all on is individual practice visits as well around your provider engagement report, so we can have more rich conversations around each of these topics. So Ed, would you find something like that helpful? Something that's at least directional gee, I'm doing great with my ADHD prescribing, but I wonder what happened over here on medication Y.
Sure. Oh, absolutely.
Okay.
And as one of the senior members of the community now, I mean, we have seen so many iterations of this, going back to the 80s, when we would get our report cards and they weren't supposed to be punitive, they were supposed to be educational, but whenever you assign dollars to it, it does become somewhat punitive. The nice thing about AHP over these years is it really has been more of a carrot, not the stick, and I appreciate all that. So yes, if we're doing it in that manner, I think that would be extremely helpful. I think the more that we can get things pushed out to us, probably the better. In some of the Academy of Pediatric listserv, I don't know how many people are on the SOPM listserv, but all of a sudden there's some threads about people who are talking about PCMH and how the organizations that they're with are not really basing anything on PCMH anymore. And as we have gone, a lot of us have gone through the hoops and all as Don Berwick refers to them, the stupid, silly rules to become a PCMH certified practice. You start to wonder how much of this is really bureaucratic and how much of it is really adding to how we take care of our kids. So as long as it helps take care of our kids, not only individually, but as a population, then I think it is worthwhile. Sorry for the long answer.
That's great.
That's helpful. Thank you.
Could I ask a real quick question on the, and this is for everyone, but on that thought, like punitive versus positive, like as a designer, just of the dashboard, when you look at this, did it ever cross your mind as what I call the emotional needle? Like, is it positive or negative? Are you guilting me, or do I feel like I can be a great citizen now and treat children much better? Or did it not even ever cross your mind? Is this just numbers and data that you look at? Any idea on this emotional needle question when you see this? Did anyone see it
Well,
as negative?
I almost
Yeah.
feel like the citizenship, I mean, I think it's more positive than what we have right now.
Okay.
But I almost look at the citizenship thing as being a participation award. Everybody gets a trophy for being on a team.
Okay.
And
Right.
for the citizenship, that looks really quite attainable. If all it takes is calling pharmacy to ask them questions or to
Right.
participate in these meetings or to attend
Right.
the clinical grand rounds. I mean, you're making it pretty easy. So
Mhm.
I think you are helping us. And I guess the more green you see, and green and blue are nice colors. So, they're calming
That's
colors.
true.
Hey,
That's
Ed,
true.
we're going to
Believe
evaluate
me.
actually the quality of the questions. So if the questions seem like good ones, then you get the
Oh,
trophy. If
okay.
not,
Thanks. And if you take the executive director out to play golf, does that help?
that's a grand idea.
No, that
just
takes points
brainstorming.
away. That just takes
no.
points away.
No,
my
no.
fault.
Hey, I
Seriously though, Ed, if more of you were doing these types of things, we wouldn't need it, right? I mean, it wouldn't even cross our mind to include it. That's, I feel like it's something we need. You're just a great example of someone who it comes to you naturally to be a good citizen.
I honestly think there's a lot of good citizens on this call here. You guys have all participated and fully in anything that we've tried to lift and in these meetings and above and beyond these kinds of meetings in terms of the work that you're doing for engaging for kids in the community. So it's kind of it's an easier space here, but there is room to move for some people and for some practices, definitely. I think one thing I just wanted to mention, I was reading some of the chat and I don't want to move away from this too much, but there's questions about that this doesn't necessarily get to all of the other Arcadia measures or the quality measures we need to be looking at. And so that's quality measure box, Bob, right? Well, ultimately that will click and will build out into the quality measures. So people will be able to have that pop out. And if you're a pediatrician, you'll see how you are doing and how your practice is doing on a quarterly basis.
Right.
In terms of
Like
achieving. There you go.
Similar to readmission.
Right.
Right.
So it's tough because so for us in peds, it's tough, it's readmission. We're not engaged in that, but I think but this is the notion of where this report is going.
Right.
So there will be more specifics in that space that are relevant to the measures.
Right.
And I just wanted to add one thing for the team. The reason we are including LARC here is that when we think about the initiatives that we've been working on collectively over the last couple of years, LARC deserves a focus and finish. We're not done in that space. And maybe you're never finished, but this is not, we'll come back and talk more about the components of that. But the LARC participation doesn't mean everybody has to train to place LARC. It means we're encouraging people to at least get the LARC reproductive health talk from the Huckelman Center so that people are doing evidence-based reproductive health counseling. So that's that's a win. That's a plus in that category. So I just want people to know, we'll come back and we'll talk about that more and build that out. But I don't want people to think we're expecting that every single one of you is going to be a trained LARC insertion provider. That is not what this is about. That's not actually what we need as a community. So we'll come back to that. Thank you.
Nice.
I can tell you, LJ, we are having the LARC talk on Friday.
Yes.
So
I heard that. I love it. Genesis Peds, way to go.
They were telling me when I talked with them, Jessica, I think is her name, that they're updating their website because it's a little bit confusing at the moment and not very directional in how to contact them.
Yes.
But if you
We'll
send her an email,
Yep.
we'll back to you.
And actually, we're partnering with the Huckelman Center on this, and with Jessica. We had Jessica join our meeting where we were looking at this provider engagement report for the pieces we're building out. So yeah, definitely trying to connect the dots between the good work that's happening elsewhere and also within the AHP network. Thank you.
Can I make another comment too? I like this kind of dashboard. I have to say that I don't look at them very much, but that's partly because I haven't found them terribly helpful. And when I get the paper copy of gaps I spend a lot of time and a lot of staff effort trying to follow up on them and finding out that they don't really match. And what I have in my record and what I see and I'm doing doesn't seem to match. And it doesn't give me a lot of confidence in moving forward, as others have said. But that's just one thing that I observe too. But the other, and I would, about citizenship, I would thank you for doing this, because we have been attempting to do something like this in our own office. With 8 physicians, there is a different level of participation by different people, and we think that that should be recognized. And it's been a difficult conversation, or even trying to think about how that should go forward. And this is a very nice introduction and a nice way to bring that up. So I appreciate that. And my last comment, as I was looking at this, is that this is all very nice about what we should be doing and how we should be following up and how we should be behaving. But I will tell you, it's no small frustration to us in the practice, patients' behavior in response to this. And when you are talking about meeting quality measures that have just visits in the office for well child visits and immunizations secondary to that, I have had more families in the last few months, not even at the beginning of COVID, but in the last few months, question, why do they have to come in? I know my children. Why do I have to come every so many months? Why do I have to come every year? Why can't I bring more than one? Why can't I do this? I don't want to be in your office. I don't want my children sick. I don't want, and it is a little bit frustrating. And I know you don't work directly with the patients through AHP, but I have often wondered if there isn't some insurance-based initiative to help encourage their participants to meet a certain level of participation. You know, if you're going to, and I'm not sure how you do that. If they're paying for the insurance, they get the care, it's free for well children. I don't know how better to get people in. We have started to let people bring more children at a time, and I've brought them in the back door if they refuse to wear masks, and I, do all sorts of things to try and get them in. But I get really a bit frustrated and discouraged sometimes by the expectation of patients that we are just where we are and at their beck and call. They call and they want an antibiotic, or they want this letter, or they want this done, or their specialist isn't available, so we have to write their prescription for them because they can't get a hold of them, and we feel like sort of glorified gophers. And that's enough.
Wow. That's heavy. It's a lot there, right?
I think there's a lot to take away from your comment there, Kathy, and your question about, ways that the insurers engage with the patients that, are on their rosters in terms of encouraging that, preventive care doesn't inherently make sense to people. It does to us because we've trained to understand why that happens, but I think it doesn't inherently make sense. And I think when there are fears about coming in, when people are stressed, beyond stressed, where they just don't want one more thing to be added in. And I also think just with the increasing social determinants of health needs, the economic situation for our families, the fact that we've done some telemedicine, I know we were all worried about like what happens when you're not doing telemedicine to the same level, and people really do need to see kids for well child visits. It's important to have hands-on. It's important to be present. I think we've got work to do as a team on our end with the insurers to help support your work. So thank you for that. And I think we can follow up on that.
Nice. Okay. And I think on my end, I only had one other small question because I haven't decided this yet, but when you glance at this dashboard, do you have a preference, or would you have a preference as to the toggle when you open upon entry? So you imagine that every design has to have a login. You log in, you open this. Would you have expected it to be on individual or practice? As a specific, that's my most specific question. Or don't you care?
Start with the practice in my vote.
Okay. Is there a good, okay. That's
You
anyone
want a
else?
reason?
Yeah.
Because that way you can take a look at the whole group and then you can take a look at yourself and compare to that.
Okay.
As compared to, I don't know, maybe that's just
Interesting.
my psyche.
Interesting. Right. No, I understand that thinking, that line of thinking. Right. Any other thoughts? And counter that?
I think it's nice to have both.
Yeah.
And perhaps the practice level is good first to give you some perspective, but it is just nice to have both, to be able to feel like you can see where you fit in all of that and what the expectation is. And it's not meant to be guilt driven. It's just, you do better with knowledge that if you know.
I agree.
There's other
Nice.
comments in the chat for yes, see practice first and
Oh,
see.
good.
So
Good, thank you. And that concludes it for my questions. Thank you for inviting me and for listening to my questions and giving me these great answers. I'm going to go back, listen to the recording again, and create a great product for all of you. So it's exciting. Thanks.
Bob, on behalf of our team, I just want to, and the team of pediatricians and family physicians and nurse practitioners on this call, like, thank you so much. It's really, it helps that you want to hear our feedback and that you pay such close attention. And you guys, like Bob ran this meeting with the adult PCP group and has listened again through their, reviewed their recording and is really taking the feedback to heart. So the comments that you've made, both in the chat and verbally, are being heard and will be considered in this. So thank you.
Thanks, Stu. And just like a detail, I know we're recording this. I screen grabbed the chats. I don't know if chat transfers to the recording, if you know what I mean. You know, it doesn't. So I screen grabbed and okay, well, good, thanks. Failed. It failed me one other time, and so I've been grabbing. Anyway, good. Thank you. Okay. Thanks.
Christy or Renee or Kim, do you have other?
I have one thing, and I think Christy, you had a quick update as well. You were going to share?
Yeah.
I can go first.
Go ahead.
Okay. So I just want to use this opportunity to remind folks about our new partnership with Medline. We have talked about this a little bit on the COVID call. It's been in the most recent network news. I think we've actually popped it in the COVID email a couple of times. With this, our partnership with Medline, we're excited that our AHP participating practices, if they contract with Medline and Provista for their medical supplies, PPE, tons of other stuff, it's been, for the practices that we piloted this with, the average savings was 28% on their medical supplies. So we really think it's worth your time to reach out to our to the sales rep there, Jennifer Taskin. I will send this out after this meeting, but really encourage you to consider switching your business over to Medline and be able to take advantage of the same favorable pricing that UR Medicine gets. And you can imagine the kind of purchasing power they have, and you'll be able to access that same pricing. So this is a great opportunity for your practice, and I just want to encourage you to follow up on that. There will be some outbound outreach as well, but in case you've got the time, or your admin team does, and you'd want to point them in this direction, really encourage you to do that.
Okay, my turn. Last but not least here. So I just wanted to give everybody a quick update on the 2021 measures. We are working with Arcadia to get a final timeline on when those are going to be posted. Our target right now, we're fingers crossed, it's going to be in April, hopefully earlier part of April. But we will be having an update to the AHP website with all of the 2021 definitions and the thresholds and information about those coming in the next week to two. We're just in final edits to make sure it's accurate. The measures that you're going to be seeing on your dashboard aren't changing. A few are dropping off, actually. So what you will be seeing will be the adolescent immunization combo 2. That'll be 10 points. The 90th percentile is 39.9, and you'll be able to see this on our website even before it gets into Arcadia. That's up about 3.89%. Childhood immunizations, combo 3, 10 points. The threshold isn't moved too much. It's at 87.32. It's just gone up less than 1%. Lead screening is 10 points. That threshold is 91.37. That went down a little bit over a percentage point. Well, child 15 months will be another 10 points. That's at 90%, and it went up less than half of a percentile. Depression screening will continue to be shown. It's report only though, while we're continuing to work out the data quality issues. So that's what you'll be seeing once we finalize things out. The definitions themselves have not changed much. So what you're seeing now, other than the targets and the points, those aren't changing. So you'll be seeing the final points and thresholds early April, hopefully.
Thank you, Christy. And we'll get all that out to you guys in writing, because I'm sure you're all like, wait, what? How many?
Yeah,
But how many
yeah.
points? What percentage?
Just
So
a quick one.
yeah, there's just a quick overview. Just to let you know, there's no shockers that are coming this year. I think that's the most important thing to know. And with that, I would just thank you all for your extended participation. So much for me thinking we were ending early, but like, thank you for hanging in there with us. Thank you for your feedback. To those of you who put messages in the chat that did not specifically get addressed or answered, we will be reviewing these and we'll try to get back to you. If you had specific questions that weren't, you guys were very chatty in the chat, but thank you for those of you who unmuted and for staying with us. I hope you all have a great night. Thank you to the AHP team and Bob. Thank you so much for joining us.
Thank you.
All right.
All right.
Have a good night, everybody.
Bye, everybody.
Take care.
Thanks.
Bye-bye.